All right, so you're on live. May I have your attention, esteemed faculties and delegates? I would like to take few moments of your time to introduce myself and the faculty members of the session. Good evening and a warm welcome to all the dignitaries present here. I'm Ankita from Clarnet, serving as the designated session assistant to ensure a seamless experience. Clarnet stands as India's most relied upon digital platform, offering a multitude of enriching services exclusively for doctors. Planet is very proud to serve as a digital partner for this event hosted by National Neonatology Forum, Gujarat. And the focus of today's session is the preventive early detection and awareness of all the birth defect update on RBSK guidelines. So let's begin today's session, for which I would like to invite Dr. Kunal sir to take over. Over to you, sir. Kindly proceed with your talk.
Yeah, thank you, Ankita. So, good afternoon, everyone. Today is a month. This month is the birth defect awareness month. So, we would like to take the series as we present the neonatal Pathshala every Wednesday. So, we'll be taking the birth defect topics this month on every Wednesday. So, today we have expert Dr. Pratima ma'am. And before we start our session, I would request Shwetal ma'am to say a few words. She is our president of NNF Gujarat.
Thank you so much, Dr. Kunal. Yes, we will celebrate like create an awareness regarding the birth defects, so that whatever the things which are preventable, we can immediately implement, and we can give an intact survival to the newborns, which is our goal as an NNF organization. Not taking much time, I'm extremely thankful to Dr. Pratima madam for immediately accepting our invitation at the last moment. Thank you so much. And now Dr. Monish sir will introduce Dr. Pratima ma'am.
Before that, I will introduce Dr. Monish Shah, sir. He's a director of Sonal Children Hospital and Neonatal Care. He's a private practice since 18 years, and he's our executive board member for Gujarat State NNF. Previously, he has also been hold this post, and yet was also president of AOP Patan and treasurer of AOP Gujarat. I welcome you, sir, and request you to kindly start, and he will be moderating our session for today.
Thank you, Kunal. I just introducing the madam. It's Dr. Pratima Anand. She is a consultant neonatologist at Lady Haddon Hospital, the Medical College and Associated Hospital in New Delhi. She is affiliated with the MBBS in Lady Haddon Medical College, New Delhi. She done the MD Pediatric KGMC, Lucknow, DM Neonatology from AIMS, Delhi, and faculty at VMMC and Safdarganj Hospital, New Delhi. Her major achievements are she has published more than 65 publications in national and international journals of books. Her special interest will be neonatal intensive care, neonatal sepsis, neonatal research, and neonatal nutrition. Co-investigator in immediate KMC study, follow-up of immediate KMC study, neonatal sepsis biology, and role of biomarkers in neonatal sepsis. She was NNF Delhi State Coordinator and National Trainer for the Advanced and Basic NRP. And she is also National Trainer in PALS and the PALS program. National Trainer in faculty-based newborn care, and National Neonatal Trainer in preterm care packages from AIMS UNICEF. I request Madam to continue with the talk.
Thank you so much. Thank you at the outset, NNF Gujarat, for having me here. Public health, I think, is a very important component of neonatal care, and all the postgraduates and fellows should actually be well aware of what is happening in the country in terms of policy making, in terms of various programs, which are not isolated or in silos, as we will see today also. They work as a block in block mechanism, that we are treating we are doing intensive care, we are treating newborns, but then the birth defects, the follow-up, all these form a component of that neonatal care. So I'm thankful that I have been invited to cover this topic. The topic for today is Rashtriya Bal Swasthya Karyakram, which is the survival and beyond. And this topic has been given because very relevant, because on 1st of March, the government and Niti Aayog actually launched the National Birth Defects Awareness Month in 2024 in March. So it is our responsibility, collective responsibility, that whatever we can at the place we are working, we should be able to contribute in a significant way. So the RBSK was launched to, historically to speaking, it was launched in 2013 under the National Health Mission. Actually, it was NRHM, and then it is under the umbrella of National Health Mission. The vision of starting this program was to enable all children to achieve their full potential and provide comprehensive care to all the children in the community. So you see, when we say all the children, this actually we will see that it covers a wide age group. It's not just limited to newborn, and it's a wide age group which this program covers. So it is not only a social model, medical model, and as I said, it is an integrated model. So it links the intensive care, it links our follow-up care with the community in a way, and then further from the community, how the baby will grow as he becomes an adolescent, adult, and what all nutritional growth parameters, what all defects and deficiencies can be there, either it is congenital or acquired, whatever defects and deficiencies, that this program had actually a vision to cover this. And it actually tried to encapsulate upon the existing school health program under the NRHM, where the children below 18 years are covered. And the basic vision was to give free management and treatment, including surgical interventions for the diseases which are covered in this program. So in English, the RBSK actually roughly translates to National Child Care Program, a comprehensive program. And it is nothing but a systematic approach of preventing, early identification, and management of 30 health conditions, distributed popularly known as 4Ds. Whenever we say RBSK, actually what we remember is 4Ds. As a postgraduate, as a fellow, as an MBBS student, we were exposed to certain terminologies, and 4Ds were the ones which we remember. We'll just go into a little more depth here today. So what are the 4Ds? Defects at birth, diseases, deficiencies, as I said, which may be congenital or it may be acquired as a part of nutritional undernutrition and all, and developmental delays, which include disabilities. And remember that it caters from birth to 18 years of age. So why is it important? Why is it important to cover these 4Ds, and what was the reason this program had to be brought in? And now also we are continuing, and we are actually stepping upon this program, scaling up this program. Why this is so? So if you look at the burden, so to improve the human capital and its potential, if you look at the burden of the defects, diseases, and the deficiencies, more than 17 lakhs babies are likely to be born with a birth defects, which account for about 8 to 10% of all newborn deaths. And if we speak of diseases, you must be seeing in your OPDs and in certain areas specifically, there are certain illnesses including fluorosis, gentle caries, eye problems, xerophthalmias, which can actually lead to vision defects. Rheumatic heart disease, which was once upon a time a very, very prevalent, and because of the awareness which was created, it is now becoming a rarer entity. Similarly, deficiencies, as I said, not only malnutrition, but also micronutrient deficiencies, anemia. IAP also, I think, celebrated the childhood anemia week and anemia month last month, and plus developmental delays and disabilities, where the newborn role comes, that how many babies are born with birth defects. And it's not that all birth defects are to be left alone. There are many birth defects. If their early intervention is done early, then definitely long-term sequelae can be prevented. So the deficiencies and the disabilities not only include birth defects, but simple IUGR babies, the preterm babies, the IUGR babies who are discharged from the sick newborn care units and also from our NICUs, if they are not followed up timely and not identified timely for intervention, then the defects can be, the disability can be much more than which is anticipated. So the idea came from this burden actually. So just to re-emphasize again, defects at birth, every year so many babies are born with CHD, more than 1 lakh babies, 50,000 with clubfoot. And you see, not all CHDs are complex or lethal. So if timely intervened and surgical intervention is done, if clubfoot is actually intervened timely, then, and congenital hypothyroidism, if it is detected early and treated timely, it can be a preventable cause of mental retardation. Diseases and deficiencies already done, but I just wanted to re-emphasize on the burden that so many babies, 18 to 20 lakh children, may be suffering from SAM. And many of you are posted in pediatrics also, and most of the centers and pediatric units now have a SAM unit and a IYCF unit, infant and young child feeding, where we actually cater to the malnutrition, degrees of malnutrition, various degrees of malnutrition. The disabilities, so to speak about the newborns, ROP is very, very famous and infamous also because of the litigations it causes, and not only the litigations but also the visual defects. You see, it is our responsibility, moral responsibility as well as legal responsibility, that screening, timely screening has to be done, whether it is ultrasound head, whether it is hearing, and whether it is ROP. Because if not done timely, we know that it can affect the vision, not only the vision, the retinal detachment, actually the baby will suffer. So that is the reason, considering this burden in India. And what does this burden do? This burden actually translates into loss of capital. I mean, loss of daily incomes for not only the individual but also to the nation. So if a baby is treated timely and he's able to be self independent and he can do his early daily earnings, then definitely it will be contributory to the nation. So that we should remember. And now coming to the details of the RBSK, this was the background that why this program is very important and why we all should, as a pediatrician, be aware of the burden of the disease and what actually it can affect. So under the RBSK, as I told you, there are 30 illnesses which are covered. The defects to enumerate are neural tube defects, Down syndrome, cleft lip palate alone, or palate alone, or lip alone, talipes, which is clubfoot, developmental dysplasias of the hip, congenital cataract, congenital deafness, congenital heart diseases, and retinopathy of prematurity. Deficiencies, remember micronutrients like anemia, iron deficiency, which is anemia, especially severe anemia, vitamin A, D deficiency, SAM we have been talking about, and goiter. Childhood illness, do not forget that skin diseases, otitis media, these are also covered under this program. And otitis media is one of the preventable cause of hearing loss. You see, if it is actually progressive and it progresses to chronic form, it can actually lead to hearing loss, long-term hearing loss. Reactive airway diseases, dental caries, and convulsive disorders all are covered in these childhood diseases. Developmental delays and disabilities, all kinds of delays in all the domains, including motor, cognitive, language, behavior, autism, learning disorders, attention deficit hyperactivity disorder, and others like congenital hypothyroidism, these are all covered. So I think when we are working on floor, when we are working in the unit, please do remember some part of this list. You need not by heart it, but you should be aware that there is a program, there is a scope. We'll see how this actually helps the parents. So what are the basic principles of this program? So the basic principles, we saw that there is a background, there is a burden. It's not unnecessarily being exaggerated, but there is indeed a burden, and it's not only the defects in congenital form, but also the diseases which are acquired as the child grows, as we saw, micronutrient and SAM, plus the diseases which can be prevented by timely screening, plus the diseases which are inherent because of the IUGR status, because of the maternal malnutrition. The baby may be growth restricted at birth. The baby may be born preterm. So how to timely intervene to prevent disabilities in them. So the principles of RBSK is a comprehensive screening. It's not only about the visual defects or the birth defects, formative defects, but it's about the holistic care of the child. Head screening is important. Plus, I'll show you the different modes of screening, how we can actually screen depending upon the disease which we are anticipating or suspecting. As I said in the beginning itself, it covers a wide target age group from birth to 18 years of age, and it has to be a holistic approach which should enable the mapping, from which area certain deficiencies are coming, from which area there a hypothyroid belt, is there a sickle cell belt. So how did we come to know about all these belts or the prevalence of the diseases? So once we have screened, once we suspect, once we are aware of these diseases, and we have to look at these diseases as a holistic approach, we will be able to map where these diseases are actually occurring and what can be the preventive strategies. So as I said, there are different modes of screening. Some of the defects or the disabilities are visible. I mean, there are visible birth defects, which are very obvious, which a parent can also identify, which a layman can also identify, which are neural tube defects, cleft lips, cleft palate, and it may actually be a stigma for the society, clubfoot. So how do we screen that thing? We actually visually screen, but then we have to look for the associations with these defects. So we have to do a complete head-to-toe examination. If a neural tube defect is present, visible, it's there. Obviously, you have to look for the genitalia, the other tracheal fistula. There can be associations with one defect. So we need to have a complete examination, proper head to toe, and if needed, certain non-invasive and invasive investigations to look at the internal defects which may be there along with the visible birth defects. So this is a group of visible birth defects. Then there are functional defects. What does functional defect mean? That although they may or may not be visible, if you carefully examine the eye for red reflex and all, you will be able to detect congenital cataract, congenital glaucoma. It's not a routine to screen for glaucoma, but yes, functional defects are there. The baby may be presenting with some symptoms, congenital deafness. So how do we identify? We all know that, here there are hearing tests depending upon the age of the baby, OAE or BERA diagnostic, sound that be used to detect these functional defects. Then we all know that there are certain metabolic disorder, inborn errors of metabolism, familial metabolic which are inherited. Some of them are listed here, like congenital sickle cell, congenital adrenal hyperplasia, G6PD, congenital hypothyroidism, especially if the maternal mother is on a certain drug for thyroid disorders. So here we to do certain blood investigations, and there is a debate of universal screening versus selective screening. But yes, the trend for congenital hypothyroidism is towards universal screening, that we should not be missing even a single case of congenital hypothyroidism, because it is easily one of the preventable causes of mental retardation. In chromosomal abnormalities and genetic disorders are a constellation of disorders, the most common being Down syndrome, and it is the one which is covered under this program. So how do we suspect? We all know there is a facies which is there, there's the phenotype which is there for Down syndrome. So once a healthcare provider identifies it, our duty is to screen for the defects which may be associated with this syndrome, and not only detect, but also timely referral and how to make them, as I said, independent as far as possible for their daily activities. Neurological disorders like cerebral palsy, IUGR, as I said, prematurity IUGR. So how can we identify? We have to follow up timely, and we have to detect early tone abnormalities or early delay in milestones. So that we have to do. So the second key component of this program is there is a wide range of age group which is covered. So we see there is birth to 6 weeks. So this has been divided for ease of operationalizing this program as birth to 6 weeks, 6 weeks to 6 years, and 6 years to 18 years. So as a pediatrician, one should be aware that between birth to 6 weeks, what all disabilities and deficiencies and defects can manifest. And some of them to enumerate, as I already did, was timely screening for premature brain injury, for ROP, for hearing, for metabolic bone disease, for heart disease, which manifests sometimes at 4 to 6 weeks. It may not manifest at birth, plus a complete anthropometry, identification of microcephaly, small head, identification of a baby who is born IUGR or small for gestation. So these babies have to be under the radar, and you have to keep them under follow-up. If not, if the baby cannot come back to your hospital, tertiary care hospital, you have to link. The referral linkage system has to be there. There is an implementation slide which I will show you how to actually try to, you cannot do everything. I mean, you are managing the babies here, you are following them up in your follow-up clinic, but there may be socioeconomic reason that the family is not turning up to you each time you're calling them. So you have to give them a referral linkage to a place where the family is closer to, resides closer to. So that's where our role comes. 6 weeks to 6 years, especially in the community, preschool children. So how this age group is catered? There are a lot of camps which are organized We are trying to empower the ASHA community health workers more and more, who are already given a lot of roles and responsibilities in the rural areas. Then they have been given a checklist. They have been given some charts to identify the delays early. And as we see here, that child health is monitored twice a year at the Anganwadi centers, and not only monitored, but if referral is needed, we have been to Madhya Pradesh recently, and there are district early intervention centers which are actually placed in a lot of districts now, even remote areas also. And once the child becomes older, so what can be the deficiencies? So there can be learning disabilities, there can be poor performance. So all these things have to be looked for, and this also routine monitoring has to be done. So what are the other principles of RBSK? As I was coming to it, this program plans to support the parents. It's not the lack of dependence on the parents, but actually parents need to be supported. There are multiple reasons why the parent may not come for follow-up, even if there is a visible birth defects. As I said, there is social stigma which is attached. The baby, they may be hiding the baby. They may not be showing the baby. They may be thinking that, what can do? It cannot. I mean, nothing can be done now. So that kind of thing may come into the parent's mind. So what the community health worker or what the medical professional can do is, the first time there is an opportunity to interact with the parents, we need to tell them that there is a scope of financial support, monetary support, and need to be given a specific DEIC number or a district early intervention number, or the facility with the surgical interventions there are available. So that will eliminate the lower rate of follow-up which happens, isn't it? So another principle is efficient utilization of resources. I will just show you one or two pictures where there is an umbrella of follow-up care which is there. Under the same roof, on the same floor, there is hearing assessment being done, there is an eye assessment being done, there is anthropometry being done, and there is developmental screening being done. So efficient utilization of resources with multidisciplinary involvement. So that is another principle. Record keeping is very important. So why is it important? As I said, mapping is important. Most of the defects may be inherited. Most of the defects may be running in a certain geographical area. Most of the defects may be running in the family, or maybe geographically, we have seen during our undergraduate, postgraduate days that there is a certain belt where fluorosis is more common. There is a belt where goiter is more common. So the nutrients in the environment which are there. So we need to have a record keeping. We need to screen track, and government is actually trying to digitalize and associate the various softwares with all the national programs, so that we can actually map. Mapping, what does it help in? It helps in actually not only mapping the area, but also further policy making. Which area needs, which state needs which priority. So that is why. And we have been talking about continuum of care from birth till adolescent and various sectoral linkages. And not only that, once we have screened and identified a defect, there has to be a diagnostic center there to identify the internal defects and treatment and management, which is a challenge. Lack of surgeons, surgery units, so that is a challenge. So I was telling you that there is an implementation slide which is there. So this is all the knowledge, this is all the plan which is there for this program. How do we operationalize it? So for operationalization, there has to be a linkage. We cannot work in silos. We cannot just identify and then leave the baby there. Yes, I have identified this syndrome. I have seen the features and it is tallying with my textbook. So that should not be the end. So as I said, we should try to link them to the early intervention center at their own district as far as possible. If it is a city, if it is a medical college, if the parents are residing in the city itself, that is good. They can follow the same tertiary center. But most of the times, as we know, there is a population which comes from the rural area, which get delivered and which actually go back, or they come for OPD visits and then they go back to their village. So we need to refer them to the nearest center, and we need to tell them that there is a monetary aid which is available through this card. So what is the government doing? Just a pictorial depiction of the same which we have been talking about. So the step one is health worker. It may be us who are working in the neonatal unit, in the pediatric units, where there is first screening which is done, and where the birth is happening at home, or the baby has not been seen at any facility, so the community worker screens at home at Anganwadi center, and then she actually identifies it and she refers to the nearest doctor, who actually has to refer him to the district pediatrician if there is no pediatrician there, to the further step, and then the last step would be referral to a tertiary care hospital. And in between step 3 and step 4, intervention has to be started. So as I said, even when in smallest districts of the states, now there is an identified district early intervention center where I'll show you the team of DEIC also, just to have an idea for you that what is the team composed of, what do the DEIC centers do. And at the tertiary care hospital, we need to give them packages, need to map them from where they're coming, and feedback and referral forms, one of the component. So what does it do? The capital, I mean the loss of capital. So the average person or the average lower middle class, as per the socioeconomic status, he can actually be below poverty line with amount he has to spend for his medical care and for this comprehensive management of birth defects. So to reduce his out-of-pocket expenses, to reduce the beneficiaries' out-of-pocket expenses, this program actually aims to give free of cost management and treatment at each stage, including screening, treatment, the counseling, follow-up, training of the persons who are actually doing physiotherapy or interventions, and then softwares and reporting. So that is what it is, not in silos, but if we have to integrate, it's not so easy as I'm just presenting it, but it's not easy to do, because you see there is multi-pronged involvement, multi-pronged factors which are leading to these defects, and which not only are contributing to neonatal but also infant mortality. Not only mortality, you see the long-term morbidity and the loss daily, what we say na, daily activity, loss of daily activity. So that is what is being done, and it's not simple. It's not simple, but what we can do is this part where you are working in one unit, in the pediatric unit, where you can actually identify, immunize them, monitor their growth, identify any defect timely, try to refer to the earliest specialist whom you can actually identify. But there are certain difficult to modify factors which are there, of course, but let us focus on what as pediatricians we can do and know the risk factors. So this table actually shows that there are certain risk factors and there are interventions. So let us focus on what we can do when the baby comes to us, at that stage what we can do. So this is just to give you the hierarchy. The previous figure was to show the step 1, step 2, step 3, and this is just to show the referral points. Like in facility-based care, we have certain referral points: a community health center, a primary health center, a district center. So here the first referral point is labeled as district early intervention center, and subsequently, depending upon the type of surgery or the intervention he has to be given, there is a network of hospitals which is already identified. The government is trying to identify and get to a pool of these things. So the hub of all these activities remains the DEIC. Remember, the District Early Intervention Center, which actually forms the center of this. The purpose of screening is to intervene. So intervening, the first referral point is DEIC, but DEIC is not the place where all the interventions and all the surgeries are being done. So ultimately, what is to be done? This DEIC has to be a licensing officer between these two. So licensing unit between these two. So what we have to do is we have to refer them to the appropriate center where the facility for management is there. So what DEIC does is it helps the parent in confirmation of diagnosis. As I said, it's a licensing unit. It helps to coordinate between the screening team and the intervention team, and then he has to actually track, and the baby will the child will go back to his hometown or his home place. So from there he has to track and backtrack and identify the timely referral if needed again. So that is to be done, and then of course reporting is to be done. Genuine reporting has to be done. So, so what is the manpower I was telling you that DEIC who are there? So there are medical professionals, there are paramedics, there is support staff, and there is a manager, administrative manager. So medical professionals, there has to be one pediatrician or specialist in echo who can actually identify the structural heart disease. Then for dental illnesses, there has to be a dental doctor and ENT and ophthalmologist, because we saw that 30 illnesses, the list had actually otitis media, ear problems, congenital glaucoma, cataract. So all these were there. So for that, we need a multidisciplinary presence of specialists. Paramedics for identification of hearing defects and for screening of various domains of developmental delay. So clinical psychologist, optometrist, and a dental assistant. And of course, 2 lab technicians and staff nurses. And support staff, we need to have a special educator, social worker, and for record keeping, we need to have a data entry operator. So where we have reached and what we have achieved is, this is just an update from 2 months back, that almost 157 crore children have already been screened, and 10 crores children identified with selected health conditions. And of these, 50% children have been provided with some form of secondary and tertiary care. And you see, with the efforts in the inception of this program and the launch of this program, 367 DEICs have been made functional throughout the country. So this is an achievement, and we need to build upon it. And as in the intensive care is improving, the antenatal care is improving, antenatal ultrasounds are coming up. So the identification and screening and the survival of the preterm, more preterm babies are surviving, more of IUGR and extreme low birth weight babies are surviving. So we need to be all the more active, that yes, there can be a scope of coordination between us and the interventions which are actually needed. So this was one of the DEIC from Madhya Pradesh. We are actually mentoring a few units there now. So under one roof, as I was saying, and at Safdarjung Hospital also, we could establish one, not DEIC, but one follow-up, complete child developmental center, where not only a play area and relaxing area is there, but a physiotherapy, tools for testing, including Bailey's or DASI, the anthropometry, and audio and visual testing. So these facilities are there, and it is a comprehensive unit which is there, DEIC. But of course, reporting, data maintenance, and tracking is very, very important, because there is a tendency that all these diseases and illnesses, they may be getting lost to follow up. So that is the challenge which we may face. And we are facing, in many units with footfall, the ones which we call for screenings, the repeated screenings. Most of the times, 1 or 2 screenings are missed by them, including the ROP ones also. So I wanted to touch upon, as a pediatrician and as a neonatologist, that RBSK gives guidelines for retinopathy of prematurity, and it also gives us the babies who should be screened. So there are a lot of screening guidelines which are there for retinopathy of prematurity, including the ICROP, the American Academy of Pediatrics. But this is the Government of India guideline, and as per it, screening should be carried out for all the infants with either of the following: birth weight less than 2,000 grams, gestational age less than 34 weeks, and you see bigger babies, 34 to 36 weeks, but with risk factors, any of the risk factors like prolonged ventilation, blood transfusion, apneas, or if the clinician feels that he had an unstable clinical course, those babies are also to be screened. So remember that it's a little different from international standards. The reason is that because of the resource limitations, there may be certain gaps in monitoring of the oxygen administration which the baby is receiving. So that is why, and the sickness level, illness level, the delay in referrals. So that is why the cutoff is birth weight of 2,000 grams and gestation of 34 weeks. And we should screen at 4 weeks of postnatal age, and for less than 28 weeks and less than 1,200 grams, we should be screening a little early at 2 to 3 weeks after delivery. So what do we, look forward to? So what the government and what the program managers are now thinking is, maybe it's time to expand the capacity of RBSK. There were 30 illnesses, but now maybe the rare diseases, which are now again another domain of interventions. So maybe the rare diseases and other genetic diseases should be included in the list of illnesses covered under RBSK. As I said, it's easy to show pictorially that yes, referral linkage is required. There should be linkage between community and tertiary care hospital, but there has to be an enabled system, including proper ambulances if needed, a dashboard indicators that where the surgical intervention can be done, which are the hospitals which are providing interventions, and reach out to the private setup through public-private partnerships, because the resources are limited everywhere. So if a particular ophthalmologist is not available who is trained in screening for ROP, or in fact managing ROP in the form of laser or VEGF, then why not have a partnership with the private hospitals or the private setups where the baby can go just for intervention and then come back to the parent public hospital. So this kind of things we are looking at. As I said, mapping needs to be more strong, and our data and record keeping actually needs a lot of, there's a scope of a lot of improvement. Generate awareness, not only amongst the parents, but also amongst the healthcare providers, that this may be not a lost game to say. But as a youngster, we used to think, yeah, birth defects, so we should, I mean, we were not focusing on that. We're more focused on the intensive care or the ventilation. But you see, once to save the baby, the actual, what to say, the contribution begins then. You have to make him functionally good, I mean, functionally appropriate, isn't it? Intact survival. So expanding the services, as I said, for other genetic disorders, genetic counseling also, with a lot of whole genome sequencing coming. I don't know what's the scope of this, but there is a suggestion on that. Diagnostic services, improving the genetic diagnostic services, improve the repository more with more comprehensive data, and of course, strengthen and link SNCUs also with this program. I think we have seen that many of the SNCUs are now aware, and there is a team which is actually monitoring for this RBSK implementation. Yeah, Shwetal.
Thank you so much, Dr. Pratima. It was really a crisp and a wonderful presentation. And yes, I can share some of my experience. Like we have a DEIC center in our college, in our department, and it's a center of excellence of the state, as well as one of the Dharampur center, which is also a very center of excellence. And both the centers are doing well. Yes, initially it is really difficult to gather the team and start off. But once you start off, we are really, whatever 10%, 20% a year by year, the percentage of beneficiary increases. And that gives a ultimate outcome is really a smile on the parents, which we have seen for especially the cleft lip, cleft palate. The obturator is immediately, the dental technician comes to the NICU, take the measurements, and by the time the baby is ready to feed, the obturator is ready. And their weight gain is good, and the corrective surgeries can be planned as early as possible. Many things like Downs babies are coming. For them, the early intervention is going on. We have cleft foot, cleft palate. The cleft foot, we have the corrective surgeries. So small things. If I pick up and the success stories, if you see, I can sometime I'll share my DIC success story of last 4-5 years. It's really amazing. So we need to, and government is very supportive. This team has, especially the team of DIC is able to help us in decreasing our administrative load. And so we clinician can also concentrate. Otherwise, like the phone calls for the follow-up, that has been like social worker is posted. So that is also every Friday there is a phone call for the Saturday visit. ROP screening, we have also now got the camera. So we can now cater the distant SNCU also, district SNCU also. So yes, in a way, under the umbrella of DIC, definitely there will be a qualitative, like intact survival is possible. And we will be able to more and more generate the awareness as well as prevention as well as treatment, diagnosis and treatment we can cover. Thank you so much for taking this session, Dr. Pratima. I am very thankful to our EBs who are present over here, Dr. Somshekar sir, Dr. Shilaya madam are our advisors, Dr. Urvi, Dr. Vaibhav, Dr. Vishal to join this session. And now Dr. Monish sir and Kunal can take over. Monish sir?
Yeah, thank you so much. Ma'am, Monish sir had to leave because of an emergency. So Thank you so much, Pratima ma'am, for such a wonderful lecture. It was really informative, and we are enlightened, and as I'm doing a private practice, but I still refer to a few of the poor patients to DIC center in Rajkot. But it is very helpful and very useful for the babies who are, especially for underprivileged babies are there. So it is a very useful program, and definitely a public-private partnership is also required, which will be very helpful, and we can improve the outcome of the babies who are sometimes underprivileged. Thank you so much, ma'am. If anybody has any questions, in the chat box there are no questions, are not there. So if anybody have any questions, they can ask directly. Somsekhar sir, you have any comments on this?
No, I believe that it's a very extensive program. But in terms of what I've noted is there is very little collaboration with private institutes per se. I don't know if that is your opinion.
Yeah, here in Delhi, sir, for ROP, we try to take help from the private ophthalmologists. I mean, the centers where there are. So there was an upcoming idea in the meeting which came up last year at RML only. So for ROP, we know that it is there, but for other domains, this yet needs to come up.
No, we have a pediatric surgeon under CM Setu program. And for ROP also, both of our retinal specialists are coming. Especially, they were coming as a charity, but now we have enrolled them into CM Setu. So yes, if we try to approach them for even the pediatric orthopedic surgeon, he is also doing like some many times for FOC consultation is doing, or on a concessional rate he is able to give us the corrective surgeries and all that. So yes, we need to find out this such a specialist, and need to have a liaison and communication for such services. In CM Setu program, we can call any of the specialists which are required for the this DIC services. So in government setup, this is the thing, sir, what we are practicing at Baroda Medical College.
So, Dr. Pratima, in the introduction, you mentioned the age group is 0 to 18 years of age. Many government colleges, and I think it's mainly the government colleges, treat up till 12, in some places 15 years of age.
Yes, sir.
So how do those children between 12 to 18 years get picked up? Because they must be getting lost, because medicine people may not be aware of this RBSK. I'm not sure how it works in those
Yeah,
places.
at Safdarjung, we used to involve them, sir, especially for the CGHS beneficiaries and all. We used to, whenever, 18 years children used to get referred to pediatricians only because of the RBSK and all. They used to come to us, but then we used to take help from the medicine people, because what to say, as a policy, so PD registrations is till 12 years for pediatrics. So the only thing would be communication, and again liaising, creating meetings with the medicine people. So that has to be done. It is indeed a challenge that most of the pediatric OPDs either 12 years, 14 years maximum. So at other
I think if the government of India is recommending child as up till 18 years, government hospitals need to change their age range to 18 years of age, and I think that is.
Yes.
But then, sir, we need to have a special ward for adolescent. The size of the cots we need to, and that to a female as well as the male. So yes, the government has to take up. Yes, policy implementation is required. Otherwise, this is a no man's land. This happens with our nephrotic syndrome patient. We are following up till 13, and suddenly we have to shift them to the medicine. Patients literally cry for that.
Ready to go to medicine now. Yes.
So yes, I had a 30-year-old patient today, like not yesterday. She had issues with medicine department, so she came calling back, because I used to see her with issues and I had to go and ensure that she went there. And
same thing we are doing for our nephrotic, our hemophilia, epilepsy. All those patients who have followed us for last 13 years, we have to immediately, after one day, on the birthday, they are shifted So yes, we
No,
are
no, this
facing.
is
It
this
has
is
to
the
come
patient who
from
gave.
government.
This is a patient who has given birth. Her kids are now 13 years old. Still, they come back and interview. Should they come back?
Okay, sir. Okay. Kunal?
Yeah, any further questions by anyone? Okay, so I think there are no further questions. I would like to thank Pratima ma'am again for the wonderful talk. Thank you, Shwetal ma'am, Somsekar sir for guiding us. And I would thank all the B members who are there, like Dr. Vaibhav, Dr. Vishal, Dr. Jatin, all those who have joined. Some seniors also, Dr. Jayesh Sonwani sir, Dr. Krutika ma'am, all those who have joined with us and to make this program a great success. So thank you all. I think with this we will end the session. Over to you, Ankita.
Right. Thank you so much, sir. Thank you
Thank
everyone
you.
for sharing such valuable insights on the platform. Hoping to meet you again on this platform very soon for any other next sessions. With all the due permissions, can we conclude the session over here?
Yeah.
Yes.
Bye bye.
Thank